Hi, I'm Dr. Fennell, and I'd like to welcome you to this module, FDA-approved medications for opioid use disorder. There's one objective for this module, which is to understand the essential information to educate a person taking medication for opioid use disorders. So we'll go through the name, the dose, the route, the frequency, indication, action, and side effect of these various FDA-approved medications. The three medications that we'll start with are opioid use disorders and overdose. So this is an overview of the medications that will be described in this module. Methadone was approved by the FDA in 1972, buprenorphine in 2002, and naloxone was FDA approved in 1971, and as an auto-injector approved in 2014, and as a nasal spray in 2015. Methadone's mechanisms of action are that it produces a blockade of the effects of heroin, morphine, and codeine, as well as some semi-synthetic opioids such as oxycodone and hydrocodone. So in other words, it's an agonist blockade. There's a full opioid agonist that acts at the mu-opioid receptor to displace opioids. And if this medication is maintained for long enough, the stabilizing effect can reverse the immunological and the endocrinologic defects caused by long-term heroin use. Before initiating methadone, it's important to obtain an EKG. This is especially important in patients with risk factors for QTc interval prolongation, patients who have any previous EKG showing that a QTc of greater than 450 milliseconds, or a history suggesting previous ventricular arrhythmia. It's also important to assess pregnancy status because this is a Category C medications. In initiating methadone, the approach is to start with low doses based on treatment indication and the patient's previous opioid exposure, and then to titrate slowly and monitor for sedation. The pharmacokinetics of methadone are that it's absorbed after oral administration. The bioavailability ranges between 36 to 100%, and the peak plasma concentrations are achieved between 1 to 7.5 hours. Methadone is a lipophilic drug, and the steady-state volume of distribution ranges between 1 to 8 liters per kilogram. In the plasma, methadone is predominantly bound to the alpha acid glycoprotein, and you can see the rate there is 85 to 90% binding. And methadone is secreted in saliva, breast milk, amniotic fluid, and is in umbilical cord plasma. This methadone is metabolized by demethylation to the inactive metabolite, and it's eliminated and excreted by renal and fecal elimination. The dosing and administration ranges from 80 to 120 milligrams per day, and it may be higher for some individuals. Methadone accumulates over the first several days with a steady state after 5 days. Methadone maintenance treatment is distributed through a licensed methadone clinic. So in your area, it's important to know where those licensed clinics are located, and also if there's a space available for a referral of patients. The side effects of methadone that are shown here are the QT prolongation, which typically occurs in higher doses. There may be constipation, hypotension, urinary retention, drowsiness, nausea, and bradycardia. And the unintended side effect is an unintentional overdose or death, and this may be potentiated or inhibited by many medications. So it's very important for patients to be educated that they ensure that other healthcare providers that are prescribing medications for them know that they're taking methadone, and encourage them to use a single pharmacy so that the drug-drug interactions can be assessed. Buprenorphine is another FDA-approved medication for opioid use disorder, and this is a partial mu opioid antagonist. This has a long duration of action, 24 to 72 hours, and the effects of this medication increase until a plateau is reached. This means it can be reduced over a short period, typically 3 days, for compelling reasons, and a moderate period over 2 weeks, and then discontinued. Because of the partial agonist action, buprenorphine has a ceiling effect. That means that the effects will not increase even with increases in dosage. There are different formulations of buprenorphine. Because of buprenorphine's opioid effects, it can be misused, and particularly by people who don't have an opioid dependency. Naloxone is added to buprenorphine to decrease the likelihood of diversion and misuse of the combination drug product. So the buprenorphine naloxone, the combo formulation, comes in a tablet form, 2 milligrams of buprenorphine to 0.5 milligrams of naloxone, or an 8 milligram of buprenorphine and 2 milligrams of naloxone. It can also be in sublingual form in a tablet or a film, and it's also provided in a depot injection. The important point here is that women who are pregnant can take buprenorphine, and because the mother and the fetus will be dependent on opioids used by the mother, administration of naloxone could precipitate withdrawal in both. Therefore, the formulation for this population is to use buprenorphine alone or the mono version, either the 2 milligram or the 8 milligram tablet. Buprenorphine has been legislated since 2000 through the Drug Abuse Treatment Act, or DATA 2000. And this has restricted prescribing to qualified physicians. That means those with specialized education and a specific DEA number. The Comprehensive Addiction and Recovery Act, or CARA, Public Law 114-198 of 2016, expands prescriptive authority to qualified nurse practitioners and to physician assistants. What this means is that these providers will be able to increase the access to buprenorphine for patients with opioid use disorders. So nurse practitioners and physician assistants who complete the required training and who seek to prescribe buprenorphine can do so for up to 30 patients, and they'll be able to apply to do so beginning in early 2017. Once these prescribers, nurse practitioners and PAs, receive their waiver, they can begin prescribing buprenorphine immediately. Registered nurses have had a role in the all phases of buprenorphine treatment, and there is a guide for nurses that has been published by the Substance Abuse and Mental Health Service Administration to explain the role of all phases of buprenorphine treatment and the role of the registered nurse. So this is well within the scope of practice for the registered nurse to participate in clinics that provide buprenorphine treatment. In the initiation of buprenorphine, the first phase is the induction phase. And this is where there is medically monitored startup of buprenorphine treatment. This is performed in a qualified physician's office or a certified outpatient treatment program. Buprenorphine is administered when the person has abstained from using opioids for 12 to 24 hours, and they are in the early stages of opioid withdrawal. It's important to know that buprenorphine can bring on acute withdrawal for patients who are not in the early stages of withdrawal and who have other opioids in their bloodstream. In continuing buprenorphine, we move to the stabilization phase, which begins after a patient has discontinued or greatly reduced their opioid use. They no longer have cravings and experience few, if any, side effects. During this stabilization phase, the dose may need to be adjusted, and because buprenorphine is long-acting, once stabilized, an alternate day dosing might be possible. In the maintenance phase of buprenorphine occurs when a patient's doing well on a steady dose, and the length of time of the maintenance phase is tailored to each patient and could be indefinite. And the decision to continue or not should be based on preventing a possible relapse. Buprenorphine dosage and administration is 4 milligrams initially, and then there's an increase of 2 to 4 milligrams daily for 2 days, again with a target dose of 8 to 16 milligrams. The side effects of buprenorphine are nausea, vomiting, constipation, muscle aches and cramps, cravings, inability to sleep, distress and irritability, and there may be fever. This medication is contraindicated with benzodiazepines and other central nervous system depressants because they, in combination with buprenorphine, can increase the potential for respiratory depression. It's also important to consider that buprenorphine can precipitate a withdrawal if opiates are still in the bloodstream. The next medication, naloxone, has been the standard of care for opioid overdose since 1971. What naloxone does is it displaces the opioid from the opioid receptors. Therefore, it's an opioid antagonist. The duration of effect is 20 to 90 minutes, depending on the dose and the route of administration and the overdose symptoms. And policies do exist at the state levels for prescribing to third parties. So the website is www.prescribetoprevent.org. The Substance Abuse Mental Health Services Administration has developed an opioid overdose prevention toolkit, and this can be downloaded from the SAMHSA store and is also in your toolbox. In initiating naloxone, this is indicated for emergency treatment of a known or suspected opioid overdose. And the classic signs of the overdose are a respiratory and or nervous system depression. There's 2 sites that are shown here that show how to administer naloxone using the nasal spray and also the injectable form. So the nasal spray is narcannasalspray.com and the injectable YouTube is youtube.com, and you can also just Google naloxone for opioid overdose to find other examples. Naloxone is in different solutions. In the injectable solution, it's 0.4 milligrams per milliliter or 1 milligram per milliliter. The auto-injector is administered into the anterolateral aspect of the thigh, and it can be injected through clothing if necessary. This is 0.4 milligram to 0.4 milliliters, and it's typically packaged with 2 auto-injectors. The nasal spray is 4 milligrams per 0.1 milliliters. The side effects of naloxone are consistent with what you would see in symptoms of opioid withdrawal. There would be flushing, dizziness, tiredness, weakness, nervousness, restlessness, irritability, and body aches. diarrhea, stomach pain, nausea, fever, chills, goosebumps, sneezing, shortness of breath, and a runny nose. The pharmacokinetics of naloxone are that it's absorbed in the bloodstream in the injectable form and in the mucosa with a nasal spray. It's distributed through the body and the brain. It's highly lipophilic and it's rapidly distributed. And this medication does cross the placenta. It's metabolized in the liver and excreted as metabolites in the urine within 6 hours, about half of it in 24 hours, and nearly all of it, up to 70%, in 72 hours. So this graphic shows you the log dose plotted against each one of the opioid effects. And as you can see from the curves, the doses are increased, both the full and the partial agonists produce increasing effects. And at a certain point, the effects of the partial agonists reach maximum levels and do not increase further, even if doses continue to rise. And so the arrow points to that ceiling effect that was described earlier with buprenorphine. Here we compare the medications and heroin properties and effects. So to summarize, methadone is a full agonist. It has a long half-life, 8 to 59 hours, and there's no ceiling effect, so it's useful in patients who are dependent on high doses of opioids. Buprenorphine is a partial agonist. It has a long half-life, 24 to 60 hours, and it has a ceiling effect, so it has a good safety profile. Heroin is a full agonist. It has a short half-life, and it has no ceiling effect. And that accounts for the high rates of overdose that we've seen recently with heroin, and even more so when heroin is mixed with other opioids such as fentanyl. So to summarize, the purpose of methadone and buprenorphine are for long-term maintenance of persons with an opioid use disorder, and naloxone is used for the reversal of an opioid overdose. The references for this presentation are shown here, primarily from the Center for Substance Abuse Treatment through the Substance Abuse Mental Health Services Administration. And these guidelines and treatment assistance are both available for downloading at the SAMHSA website. Thank you, and carry on.